Honor to have you with us. Please allow me a brief introduction to our colleagues. Professor Sereti is a professor of psychiatry at the University of Bologna, where he is the director of the Mood Disorders Unit of the Department of Psychiatry. He previously held academic posts at the University of Milan, where he was the director of the Genetics of Mood Disorders Unit. He is one of the most prolific, worldwide recognized and highly cited researchers in the fields of psychiatric genetics and pharmacogenetics, especially of mood disorders and schizophrenia, psychopathology, psychiatric treatments, psychopharmacology, as well as statistical research methods. He counts, believe it or not, 650 PubMed publications with more than 40,000 citations and an H index of 94. Also more than 670 abstracts in international congresses and the textbook of psychiatry. No wonder he ranks the top Italian scientists in psychiatry. Professor Sereti was a pioneer in the old times of psychiatric candidate gene association studies. In the modern era, we are now fellow members of the Psychiatric Genetics Consortium, at least in the bipolar section. He is also a principal investigator in 20 national and international funded projects for a total of, for a budget of a total of 1 million euros. He is a key principal investigator in the Group for the Study of Resistant Depression, which is a consortium established back in the 90s to study the genetics of treatment-resistant depression, which he's talking about today, and in which our department participates to date as a collaborator through the efforts of Professor Papadimitriou, Professor Dikeos, and me. Finally, he has published various highly cited meta-analyses on psychopharmacological and psychotherapeutic interventions. His lab has been a fertile ground for the scientific flourishment of numerous young scientists, including Chiara Fabbri, Giuseppe Fanelli, Antonio Drago, Niki Antipa, Raffaella Calati, Laura Mandelli, Paolo Oliati, Stefano Porcelli, Martina Balestri, and many more. Of course, I could go on for much longer talking about him, but now is the time to listen to him in a while anyway. Professor Smirnis, Nikos Smirnis, who is the director of our department, is going to welcome you as well.
Good morning.
Good morning.
We would like to thank you very much for accepting our invitation to participate in our weekly seminars here at the Second Department of Psychiatry. We are very, very lucky to have you with us today, and we are very happy to hear on this very interesting topic that you are an expert and you are going to talk about. And if you have some time at the end, we would like to keep you for a few questions and a little bit of discussion. So we welcome you very much, and we wait for your talk. Thank you very much.
Thank you.
The floor is yours.
Okay, thank you. Okay, so I hope that you all can see, I see in the big screen that you can see the slide. So thank you again for inviting me. I'm very happy to be of use for you for this perspective of treatment-resistant depression. As Panagiotis kindly reminded, we are working on the clinical and genetic aspects. Today, I will focus on the clinical aspects that I know that is very relevant for you and for us as well, of course. So we will focus on the problem of treatment-resistant depression, what it is, what can be done usually, and which are the future perspectives. So the first point that I would like to make very clear is that depression is something that is quite dangerous for our patients. This is a quite an old study, but more than 20 years ago, but all the following evidence is going in the same line and the same direction, that after some time that our patients are with depression, they have consequences in their brain. This is the very clear example of the atrophy of the hippocampus, but it's not the only region that suffers from depression. Depression is harmful for our patients. So this is to make very clear that we have to treat depression. This could seem unuseful because obviously we should treat a disease, but we know that some of our colleagues say that depression should not be treated, should not be faced too much, is normal in life. It depends, it's normal in life, mild depression, but severe depression with the clinical criteria that we know from DSM and ICD should be treated because it's very harmful. And if we don't do this, this is another quite old study that has been, however, very well confirmed during the following years. If we don't treat depression, the problem is that year after year, there is a brain damage, a physical brain damage. Therefore, a resistant depression that goes on for more than 2 years, 3 years, 5 years, is a big damage for our patients, other than, of course, personal suffering and social consequences, but just from an anatomical and functional point of view. Said that, therefore, is needed to treat depression. What happens? Happens that, as we all know, our patients' response is very variable. Some patients respond quite easily. Okay, let's put a laser. Some patients respond quite easily to the treatment. Some other patients respond initially and then don't respond anymore. Some other patients respond in a stable way. So there is a big variability. Therefore, we have to face this variability and try to understand. In many studies during the last 10, 15, 20 years, we try to understand what happens in our depressed patients. And for example, we know that there are some kind of predictors of resistance. In the American database, it was very clear that, for example, patients with higher education, money, and living with other people and with good employment, they have a favorable outcome, and the opposite, a less favorable outcome. And also variables coming from the clinical pictures, like longer duration of the disease is a negative factor. And this is, of course, linked to what we said before. If there is a functional and an anatomical damage in the brain, of course, longer duration makes treatment of depression more difficult. And there are other factors like higher suicidal risk or heavy family loading that this links to the genetics that we will not talk today, but a higher genetic loading in terms of PRS, of depression, and for example, also other diseases like ADHD, linked to the risk of resistant depression, and of course, also the tolerability of the treatment. Therefore, we have now knowledge of some predictors of treatment-resistant depression. These predictors are quite important because if we can identify since the beginning which patients will show a treatment-resistant profile, we could have a different treatment since the beginning. However, these predictors are far from perfect, and therefore we just can rely on what predictors that we saw before, mainly a higher baseline severity and or a early onset of illness, or for example, concurrent anxiety or history of childhood abuse and lack of social support. This, of course, makes difficult our clinical work every day, because we have a big variety. We have different patients. We have patients that have a different profile in terms of clinical profile, social profile, and therefore we have to face this complexity with the complexity of treatments. We have different treatments, as we saw in many countries. Sorry, I think there is a problem. No. Okay. We have more than Sorry, can you see me? Yes. We have more than 40 compounds of antidepressant, not to mention all the combinations that we will discuss later.
Okay.
Therefore, yes, sorry, sometimes I see something. Therefore, we have a complexity from the patients in terms of clinical variables, socio-demographical variables, severity, and so on. And on the other hand, we have the complexity of the treatments. We have more than 40 antidepressants. We have many atypical antipsychotics. We have many combinations that we can use. So this huge complexity makes very difficult for us to treat the patients in the best way, each of them. Let's try to face this problem. First problem, patients may show a treatment-resistant clinical picture that may be not a true resistance. So before defining a patient as treatment-resistant, we should follow a series of steps, and these are the initial steps. First, we should not define a patient as resistant if we did not treat the patient in an adequate way. And this, there is evidence that at least 1/5 of the so-called treatment-resistant patients come from inadequate treatment trial in terms of dose or duration. It's quite common that I see patients that are treated for 1 week or 2 weeks, and then the compound is switched or the compound is stopped. And this, of course, is so-called inadequate treatment. Another very common reason that can make us think that the patient is treatment resistant, but is not treatment resistant, is the non-adherence to the treatment, the compliance. It has been reported that up to 50% of the patients in reality do not take the treatment that we prescribe. And therefore, this is something that we should do very, very carefully when we do our outpatient activity. Are we sure that patients are taking the medication? When possible, we should do the plasma level, but when not possible, we should create a very strong alliance with the patient to be sure that the patient is taking the medication. Side effect is another very serious problem. All the drugs that we are using have some kind of side effects, less or more. And therefore, we must be very careful to be sure that the patient are tolerating the side effects that the medication is causing. And we should discuss this with the patient to be sure. And we should also be sure that there are no other medical or psychiatric diagnoses that can influence the picture, like thyroid dysfunction or cortisol imbalance and so on. And of course, we should exclude all other possible diagnoses, like, for example, lack of some elements like iron, zinc, magnesium, and so on, or sleeping disorder. Once that we have done all of this, and therefore we are sure that the patient is really a treatment-resistant case, and therefore that is taking medication, that we excluded our diagnosis, then we should do what I will talk about in this presentation. We have different options to treat patients with resistant depression. The first and more simple is to optimize the dose of the medication, of course. That looks like a trivial idea, but frequently is something that is not done. And then there are other options that we will discuss in detail. Switch to a different medication, combine different antidepressants, or make augmentations, or do non-pharmacological treatments. Let's discuss one by one a little bit. First, we have to keep in mind that all antidepressants are very similar in terms of efficacy. In the very large meta-analysis by Cipriani, you see that the overall efficacy of antidepressants are very similar one to another, very similar. There are some extremes, like, for example, amitriptyline and mirtazapine, that look like to be more effective. In my opinion, this is, let's say, bias, an optical distortion, because amitriptyline and mirtazapine, you know, are very sedative, and therefore they improve sleep and appetite very quickly in the range of few days. And this could be linked to this possible superiority compared to the other. But as I always say, we should be very careful to prescribe amitriptyline or mirtazapine to patients that, for example, have atypical depression. So this is not a general rule. On the other end of the ranking, we have reboxetine that is really not so strong, but all the other are very similar in terms of overall efficacy. Therefore, it's not the overall efficacy that is guiding our choice when we are working with treatment-resistant depression. The first step is optimization of the dose. Why we should optimize the dose? Well, it's very clear because in a series of recent papers that we've published on escitalopram, but also on other compounds, we have seen that there is a very clear dose-response relation with the plasma level and the clinical outcome. At 1 month and at 3 months is even more clear. So obviously, if we undertreat our patient with doses that are too low in 1 month, and even after 3 months, we don't have any benefit or very small benefit. You see the difference is quite large in terms of low and medium-high doses. And therefore, the first take-home message is, let's not think that a patient is treatment resistant if we treat, for example, the patient with 5, 8, or even 10 milligrams of escitalopram, because they may have a rapid metabolizing status, and therefore they could have a low plasma level. So when possible, we should do the plasma level of the antidepressants that we are prescribing. But I know that is not always possible, and therefore we should increase the dose until we see a tolerability issue, and we see side effects typical of SSRIs or other compounds. So let's go to the highest tolerated dose, not too high, because here we don't have many results, but in a larger meta-analysis that we published very recently is even more clear. Too high doses do not improve response. So it's not a linear correlation. So low doses can lead to a lack of response. Average and high doses are much better, but too high doses are not so good. And this is clear also, and even more, for example, for duloxetine, where the curve here is even more clear than with escitalopram. So how we can see if the dose is too high? Well, if we do the plasma level, or if we don't have the possibility to do the plasma level, if there are too many side effects, for example, duloxetine, you can have dry mouth or stipsy and so on. So it's important to be in the central range of the dose. And this applies to escitalopram, duloxetine, but we repeated, we have time now to show for other drugs like venlafaxine, we did also meta-analysis for mirtazapine, all antidepressants, not only tricyclics, also SSRIs. So optimize the dose and optimize the time of the treatment. At least 2 weeks, but we will discuss this later. This is, by the way, what usually guidelines suggest. This is one of the most famous guidelines that I suggest for the young students that are in the audience to study. These are the Maudsley guidelines, are very useful and very, very, very well done. And so the algorithm of treatment for treatment-resistant depression is very simple, what we have seen before. And the first step is to titrate, if necessary, to the standard dose, and then see what happens. So dose optimization is the first step. But of course, we know that 1/3 or 50% of the patients, even after dose optimization, they fail to respond. And then we have to do something different. To do what? And now the guidelines are not that informative about what to do. Because if it's not effective, they suggest, for example, to switch to another antidepressant, switch again, or to do some kind of combination. It is in this part of the guideline that I would like to give more information, because this is not good, very informative for clinicians. Switch what? We switch again. we will see at the end of the presentation that my opinion, and not only mine, of course, I will show you the opinion also of others, that switching too much is not probably the best choice. Why? Let's talk a little bit about switching. Switching is the most common strategy that we have in treatment-resistant depression. That is the most obvious. Patients are not responding to escitalopram. Okay, let's switch the patient to duloxetine, to venlafaxine, and so on. Let's think about this. In the international group that Panagiotis mentioned before, we did a study a few years ago, and we tried to understand the concept of switching. Not only us, others also did this kind of studies, but I will show you our studies. For example, switch to a different class. Switch to a different class has always been considered the gold standard of switching. It was also on some steps of the famous study, American study. But however, switch to different class, therefore a cross-class switch, is not more beneficial than switch within class. This was counterintuitive at that time. We are talking about more than 10 years ago, because usually people were thinking that if you change class, you change system, neurotransmitter system, and therefore you have a better efficacy. It is not the case. It is not the case. Why? We went a little bit more in detail in this other study, and we saw that indeed the switched patient had a much less good outcome in terms of remission and response compared to the non-switched, that the one that continued on the same treatment. And this makes sense between the two findings, because if you change class or don't change class is similar than switching or not switching at all. And in this detailed analysis of this study, we have the answer about what happens. It happens that if you switch class, basically you lose time. Because in this specific study, we were switching between citalopram and diazepam. We choose those two drugs because, as you know, this is almost purely serotonergic reuptake inhibitor, and this is almost purely noradrenergic reuptake inhibitor, so completely different class and system. What happens after 4 weeks that you switch? It is very nice, because when you switch independently, if you switch from citalopram to the tricyclic or from the tricyclic to citalopram, for 1 week, nothing happens. And you have an improvement after 2 or 3 weeks. While if you don't switch, you have a small but continuous improvement. So our study was quite discussed at that time, 10 years ago, and there was much discussion also from other researchers worldwide. So therefore, this was the first time, and also the European Medicinal Agency had some statement at a certain point that the common thinking of switching class is probably not the best option, because if you switch class, you lose 1 week, because you have to start again from zero, from a different brain system. But this is not always the case. We will discuss a little bit more in detail. And this is another confirmation of this finding, because when we treated patients first with venlafaxine and then with escitalopram, again, we saw a similar pattern. I was telling you, but why? Because there are some patients where switching could be the best option. Who? The patients that show no improvement at all. Because in the previous studies, you have seen that there was some kind of improvement at a certain point, and if we switch, the improvement stopped and then it continued. But if there is no improvement at all, and we could say the improvement at all like 20%, for example, so less than 20%. If there is no improvement at all, then switching is probably the best option, but only in this case. If there is a small improvement, it's better to continue or to do some kind of augmentation or combination treatment, not switching. It is okay also if there is poor tolerability. If the patients, for example, have severe side effects, and then in this case, of course, it's important to switch compound completely. Just one word about how to switch. Of course, the switch should be done quite carefully if the compounds are very different, so the so-called cross-tappering. And of course, we should think of not doing too many switches. Otherwise, we are going on for months. So at a certain point, we should stop switching. And we should think carefully which is the next drug. This another few words of this point. What I mean with this, it depends on the clinical picture. If we see that, for example, there is a predominant insomnia or lack of appetite, then we should switch to mirtazapine that is improving insomnia and appetite. And so we should carefully choose the compound on the basis of the symptomatology versus the pharmacodynamic profile. So this is switching. To summarize, switching is not the best option, should be used only when there is a very small improvement or there are too many side effects. Combining. In this very recent analysis that has been published, I think, a few months ago in Journal of Psychiatry, it is very interesting because it seems that overall combining antidepressants versus antidepressant monotherapy is overall a little bit better in almost all the studies. This is interesting because in the past, probably you remember 20 or more years ago, there was a big debate if combining antidepressant is better, if two is better than one. Many people were saying that indeed two was not better than one because you have more side effects and you have no much more efficacy. However, it seems that this is not the case, particularly in the combination of some specific antidepressants. For example, the meta-analysis makes very clear that the antagonist of the alpha-2 presynaptic, like mirtazapine, trazodone, or answering it is less used. Here we use a lot of mirtazapine and trazodone, could be useful in combination. Why? Because they are complementary. Is almost some kind of augmentation. Augmentation is with a compound that is not antidepressant per se. Here they are antidepressant, but they are very different. And therefore, mirtazapine plus, for example, escitalopram, it looks like a good combination because you have escitalopram with pure antidepressant effect, and mirtazapine that is also antidepressant, but with some sleep improving and appetite improving and anxiety improving anticholinergic effect. And this makes sense. So let's think that the combination, particularly with some specific combination of compounds, could be better than monotherapy. However, we should be careful about potential interactions, and the website is full of repositories where you should check the risk of interaction in terms of metabolizing enzymes and the pharmacodynamic effect. So in summary of the combination is a potentially powerful strategy. However, be careful in terms of interaction. There is not much evidence about which specific combination. Probably the ones with different mechanism of action, for example, the alpha antagonist that we show and the SSRI is a good combination. Augmentation. Augmentation is probably the most interesting strategy in treatment-resistant depression because, of course, the first thing we should do, optimization of the dose. Second thing, we should do switch only if there is no response at all. Third thing that we should do is combination with specific combination of antidepressants. But augmentation is becoming more and more common and used. And in fact, in the last edition of the Maudsley guidelines, they put as first choice the combination, for example, with aripiprazole. There are quite few studies that suggest good evidence and good tolerability, aripiprazole plus antidepressant. However, of course, we should be careful because we are always talking about an antipsychotic. Also, lithium could be a possible combination treatment, is well established, well supported in literature, particularly for tricyclics, but not only. And the combination that is out since many years of olanzapine and fluoxetine. Another first choice is quetiapine. Quetiapine is very useful. As you know, quetiapine is the so-called drug for all seasons. You can use quetiapine at low doses for sleeping-inducing activity and for anxiety treatment. If you go to 150, 300 milligrams per day, then you have an antidepressant effect. And therefore, quetiapine at these doses with SSRI or SNRI, it is also a good combination. Usually well tolerated. Well, you have to be careful a little bit about blood pressure and possible sedation, but this is not usually a big issue. Another combination that I use very frequently is SSRI plus bupropion. Obviously, to patients that are the opposite of the ones that you should use quetiapine and SSRI. If a patient is resistant to depression because a lot of anxiety and insomnia remains, then SSRI and quetiapine. If on the opposite, you have resistant depression because the resistant part is made by lack of energy, motivation, and so on, and therefore bupropion, that is dopaminergic, is the best option to combine with SSRI. And this is also well supported. But however, you should be careful because I don't know in Greece, but in some countries, bupropion is not paid by the government. Another combination is SSRI with mirtazapine. That is good for patients similar profile like SSRI plus quetiapine, but SSRI plus mirtazapine is a little bit more sedative and therefore is also a good option. Obviously, there are risks here in terms of pharmacodynamic interaction. Therefore, serotonin syndrome, we must be careful about that. Another common idea is to combine with all the other antipsychotics. Therefore, you have an SSRI, and then you have patients not responding. You have diagnosis of resistant depression. And therefore, you may combine the SSRI with an atypical antipsychotic. Which one? Well, here you have choice, of course. We already mentioned quetiapine, that is one of the most strong results, aripiprazole. Now we have also brexpiprazole. That is, I don't have the slide here, but I published a review about that. You can find in literature. It's freely available, I think. Where I describe brexpiprazole as a little bit more sedative than aripiprazole. Therefore, could be a good combination for those patients where aripiprazole would be contraindicated because of risk of insomnia or agitation. Brexpiprazole is more sedative. Or you could combine also with olanzapine or risperidone. However, risperidone, there is some evidence there, but I would be more careful with risperidone because it's a dopamine D2 receptor blocker, and therefore there is a little bit risk of worsening depression, even if you have the serotonin 2A effect. However, some evidence is there, but I'm not strongly supporting the use of risperidone in combination with SSRI. Olanzapine could be, even if the evidence is not so strong in combination with SSRI. However, consider that many of them do not have a label for adjunctive treatment in treatment-resistant depression, only quetiapine. Therefore, in many countries, you are off-label, so we should be careful about that. Then we have a list of second choice potentiation if the first choice are not working or are not doable for some reason. We will discuss ketamine later also. Ketamine is coming in many countries now. You know, you can use it intranasally, intravenously, and we will show you. I will show you later also oral administration. They are starting to do it. There are pros and cons about ketamine or esketamine. Esketamine and the ketamine in some patients are indeed very effective, but not all of them. It is unclear at present which are the patients that benefit more from ketamine or esketamine. If they benefit in a very short time. However, some of them may show the confusion and dissociation, about 20% of them, not very common, but it can be an issue when administering in outpatient setting. And it's not clear how long you should go on with ketamine or esketamine, if it works, if it doesn't work. There are much studies to do on that, of course. Lamotrigine is another potential combination, very useful, very interesting. We are using it a lot. It stabilizes the mood a little bit higher, so it can be useful to give a little help in terms of antidepressant effect. You must be very careful in the titration because of the risk of rash. Of course, you have ECT. We've used ECT a lot in resistant cases. Of course, it's very effective. There are no doubt about that, but we must be very careful because people is scared by ECT. Even though side effects and tolerability of ECT at present is very high compared, of course, to 50 years ago. However, still there are issues about the use of ECT. And then there is the old story of thyroid hormones. Thyroid hormones are a good idea, usually in combination with tricyclics. There is less evidence in combination with SSRI, but this is easily solved. If you do the plasma level of thyroid hormones in the patient, you see if they may need it or not. And then there is a list. We don't have time to go through all of it. Of other possible treatments in treatment-resistant depression. Now there is a big interest in psychedelics, ayahuasca, psilocybin, and many others that are coming now out. They have similar pros and cons compared to the ketamine and esketamine. Of course, there is much research on them, and hopefully something will come out in the next few years. And then there are other small treatments, like, for example, modafinil. Modafinil, I used it quite a lot. Is a neurologic treatment used by neurology for narcolepsy. Basically, it awakens a little bit more the patient. So if you have a persistent sleepiness, modafinil is something that is helping. And of course, particularly for females later in the age, estrogen supplementation could give some help. However, the evidence is not so clear, and many others that we don't have time now to, but that the evidence is not so strong with all of them. So the third options of combination, as you see, is the more complicated, because of course increased dose is very simple, switch is quite simple, combine antidepressants is sometimes difficult, sometimes less difficult, but the augmentation implies a very careful choice of what you are combining with. And of course, connected with the switch criteria, augmentation is okay if there is an improvement of at least 20–30%. So you see some improvement, but something is left untreated. A typical example is severe depression with insomnia or severe agitation. Then you prescribe, for example, sertraline or venlafaxine, and then you have a partial improvement. Maybe the mood improves a little bit, the activity improves a little bit, but you have still very severe insomnia and anxiety. And in this case, augmentation is the best option. You augment with quetiapine, for example, or brexpiprazole. Depends. So is much depending on the clinical picture of the individual. So it's very individualized on the basis of clinical picture. Of course, you have disadvantages if you prescribe too many treatments, because when you have antidepressants, augmentation, maybe some benzodiazepines, you start having many compounds. Other possibilities are the so-called non-pharmacological strategies. Are many of them. We already discussed ECT. There is the transcranial magnetic stimulation that is quite popular nowadays, even though in our experience for severe depression, results are not that strong. Light therapy could be useful, but maybe not in Greece because you have already natural light. So light therapy usually is much used in the northern countries like Norway or Sweden. Vagal nerve stimulation, it is being used quite in some areas, but the results are not that strong and also not that fast. Usually you need months to see some benefit. So, and it's very expensive, in the range of 20 or 30,000, 20,000 euro. So it's something very, very relevant. And lastly, the deep brain stimulation that is quite effective in usually in obsessive compulsive disorder. However, in depression, still it is under research, so it's not clear where to place the stimulus in deep brain stimulation. So it's not something that should be suggested at present. Another that was suggested recently is the direct current stimulation, that is a low energy stimulation, different from TMS and different from ECT, of course. But results are not that strong. So honestly, I never used it, just to tell you. So ketamine, another word about ketamine already discussed. It has been approved. You know, ketamine quite recently in US and in some European countries, and also the neurosteroids. We didn't mention the neurosteroids because they are not yet in the guidelines, but they are very potentially useful, and brexanolone is only one that at present is suggested for females, but it could be useful also for a wider range of patients. Honestly, I don't have much experience because it's not yet available in Italy. Hopefully you will have it soon in Greece. However, from what I've seen is quite promising, although these neurosteroid modulators, this is not the only one, that there are also others quite well tolerated and quite effective. As I mentioned, ketamine and esketamine are nice and interesting and quite useful, for at least for a subgroup of patients. However, there is the issue of administration, and expensive, by the way. And therefore, probably in the future, we will have the oral ketamine. And oral ketamine or oral modification of the ketamine molecule would be quite more easy to administer and to use also in outpatient settings. So we are going to the end of my presentation. I would like to focus on the complexity that we are facing. This is a very old old paper that I published about 20 years ago, where I was curious. These were two patients that both of them had very severe depression, and one was responding quite well to the treatment, and the other one was not responding much. So a very clear case of treatment-resistant depression. And going into detail, I know that in the audience there are clinicians and also psychologists. Going into detail from the clinical pictures of those patients, we saw that indeed there were so many differences that were useful in clinical terms. For example, personality. The resistant patient had a dependent personality. She lost the husband, and therefore she could not have existential balance anymore. And also the temperament and defense mechanism were quite immature. The other one had humor as defense mechanism, and the resistant one had very projective the defense mechanism. These are technical details, but I would like to talk, because you are clinicians, that if we don't consider all these aspects, we should not clearly say patient is treatment resistant. So sometimes there are things underlying that we should consider. For example, also the social adjustment or the general situation. I remember another patient that is not one of this paper. She had a very serious problem of health and 3 children, no husband and no work. Of course, the situation was so dramatic in terms of environment that obviously here we have a kind of reactive depression. So this is resistant depression in terms of metrics, but of course is also linked to underlying aspects. Therefore, we should never forget that there are so many dimensions that we should consider when we work with our patients. And to go back to my previous review of a couple of 4 years ago, it's quite complex. It's quite complex to match the complexity of the clinical picture of the patients, the resistant depression patients, and the drugs that we have available. Not to mention genetics, but this will help in the future, not at present. But what the future will tell us, in just this last month in JAMA Psychiatry, Italian Maurizio Fava, that is director of Harvard, and Roy Perlich, two very strong experts in treatment-resistant depression, they're giving some suggestions and perspective for the future. 20 years later from the STAR-D study, we have many other things. For example, we have the mobile applications. Mobile applications, we are starting to use them. They are extremely useful. We can monitor the movement, the activity of the patient. We can see the change in mood status of the patient real time. It's extremely useful. And we can also administer some kind of, for example, cognitive behavioral treatment in an automatic way. Maybe they are a little bit less effective, but better than nothing. So this is something that it can be considered a future development. Another point is that compared to what they did 20 years ago in the STAR-D, we have new drugs, and therefore the quetiapine, aripiprazole, and brexpiprazole that we mentioned before are probably now the gold standard of augmentation. And therefore, we should consider this. So we should not base our clinical activity on the results of the old STAR-D, but 20 years past. And they make very clear the point that I made during my presentation, that the switch, the continuous switch, is not effective. Is not the strategy that is now it's clear after 20 years. I remember when I started my career 25, 30 years ago, switching was the gold standard. If a patient is not responding, you should change treatment. But now everybody is saying that probably this is not the case for the large part of patients. And we should focus on the new treatment, esketamine, this new bupropion and dextromethorphan that is starting to be available, and the neurosteroids that are there now and will be available. So I think I'm a little bit in time, 45 minutes. The last slide, what I would like you to remember from this presentation, and by the way, I'm recording and I will put in on YouTube so you can see it again if you like. What I would like to remember, first, depression needs to be treated. So the myth of not treating depression, that is a natural process, if it is so severe, it is not true. Severe depression must be treated. I know that many people is against antidepressants. They say that they are harmful, but we have a lot of medications that are harmful. Also antibiotics and aspirin could be harmful, of course, but sometimes they're needed. Antidepressants work. This is quite clear. They are very similar one to another. And switching is not probably the best option unless you don't have any improvement at all or very severe side effects. Polytherapy could be an option, but not all the polytherapies. Some selected combination could be useful. And finally, augmentation targeted in a pharmacodynamic way with the clinical picture of the patient is probably the best option for the large majority of patients. Okay, thank you for your attention, and I think we could start the question and answer session.
Thank you for this excellent